Good afternoon, everyone. All right. My topic, I'll be looking at the public health approach to the management of diabetes and cardiovascular disease. So by the end of the presentation, you should be aware of the prevalence and some of the trends in terms of diabetes and cardiovascular diseases in Jamaica and globally, the major risk factors, understand the key public health interventions to tackle diabetes and cardiovascular disease, and explore some of the WHO best buys for the management of these conditions. And then we'll explore or look at the role of pharmacists in this particular area. I just want to mention a disclaimer. I'm representing the Ministry of Health, not general, not related to the sponsors. And so I just had to put out my disclaimer there. So the interventions that will be shared will be general interventions. So this is the basic outline for a presentation. I look at the definition, public health burden, public health management, and the role of pharmacists. So what is public health? And public health is defined as the art and science of preventing disease, prolonging life, and promoting health through the organized efforts of society. And this is a definition by WHO in 1988. And there's another definition which I also really liked, which is by the American Public Health Association. Public health promotes and protects the health of people and communities where they live, learn, work, and play. And so that's a general concept. So public health is a field of science and a discipline in and of itself. And we use this approach in really dealing with population health and population medicine. So what is a cardiovascular disease? And cardiovascular disease is basically the name or group of disorders for heart and blood vessels, and includes hypertension, includes cardiovascular disease, cerebrovascular disease, peripheral vascular disease, heart failure, rheumatic fever, congenital heart disease, and cardiomyopathies. And so it's important just to highlight what this definition entails. And this is based on the World Health Organization. There are some contexts you may not see hypertension. They may be separate from the definition in other definitions that I've seen. So this is just to remind us as well, as we look at cardiovascular disease, blood pressure, high blood pressure is one of the major risk factors. And it's a risk factor and a disease in and of itself. And this is just to remind us that there have been changes in the classification of blood pressure, most recently last year. And so the data that I'll present will be based on the JNC7 classification, but there are implications for the new classification as more and more persons will be diagnosed as having elevated blood pressure and in stage 1, based on the new classification. So what is diabetes? You would have heard a lot about that from the previous session. Just to remind us, it's a chronic disease or non-communicable disease, occurs when the pancreas does not produce enough insulin, or when the body cannot effectively use the insulin it produces. And insulin is a hormone that regulates the blood sugar. This classification, most of us are accustomed to the type 1, type 2 diabetes, gestational diabetes, and there are other types of diabetes due to other causes, and they're listed here. So you probably would have covered this when you had done the presentation with Professor Tollereid. So I won't stay on this. Just to highlight, many of you would have heard about the Swedish study that was released in 2018, where they're proposing 5 new types or a new way of classifying diabetes, still around the same type 1, type 2 concept, but they have classified diabetes looking at one cluster they've called severe autoimmune diabetes, the second cluster severe insulin deficient diabetes. So the first one is more typical like a type 1. The second one found in young people, but not typically like your type 1 in terms of the autoimmune component. They're not sure what the etiology is. Then you have type 3, cluster 3, which is looking at severe insulin resistant diabetes. And so this form occurs in people who are overweight and have high insulin resistance. So their bodies make insulin, but the insulin is not, the cells are not responding to the insulin that they're making. And then they have mild, which when we look at type 2, that could fall in the type 2 category, basically. And you have mild obesity-related diabetes for cluster 4. And then you have mild age-related diabetes. So we may be seeing a new way of classifying diabetes on the horizon. And this is just for you to note. We still utilize the current classification of type 1, type 2. So why are we here talking about diabetes, cardiovascular disease? We're facing a major global epidemic. And this is really not new. It's been written about from 2001 and earlier that, non-communicable diseases, including cardiovascular diseases and diabetes, are the major leading causes of death in the world. And so this is a 2015, and as you can notice, if you notice the top 2 are ischemic heart disease. What is that? Stroke. And then you notice, right, and you see diabetes there as well. So the cardiovascular diseases feature highest. Here it shows, again, the darker colors show the highest rates of fasting blood glucose levels. But as you can see, it affects all the continents, right, throughout the world. This is just not a Jamaican problem, not a Caribbean problem. It's a global problem, and it affects all continents, irrespective of the socioeconomic status. Raised blood pressure, again, is spread right through the world. You notice a concentration in a particular continent. Which continent is that? Right, high blood pressure, highly concentrated in there, the darker areas. But, and the Caribbean, which you can't really see very well here. So the issue is this problem affects everyone. And maybe because it's affecting so many of us, are we getting very complacent about the problem? Is it just, we think of it as just something that is part of life? Yeah? Part of life, yeah? Something that happened to you, must happen to you, yeah? So maybe that's why we're looking at it this way and there's no urgency. So when we look at the global burden of cardiovascular disease, it's the most common cause of death worldwide. About 17.7 million people die from cardiovascular diseases. That's about 31% of all deaths. Greater than over 75% occur in low and middle income countries, such as Jamaica, such as many other countries in the Caribbean. And however, 80% of these deaths are due to heart attack and stroke. And for most cardiovascular diseases, the truth is that we know we can do a lot to prevent most of this burden. And based on some data out of WHO highlights that if you prevent the risk factors, behavioral risk factors such as tobacco use, unhealthy diet, physical inactivity, harmful use of alcohol, you could prevent about 80% of heart diseases by putting in public health interventions. But the interventions are not only for prevention, for those people who already have cardiovascular disease or at high risk, early detection and management using counseling and appropriate medication and other forms of treatment, lifestyle treatment is also very important. So what are we saying about diabetes? Well, 1.6 million deaths. Fewer deaths. Half of all deaths attributed to high blood glucose occur before the age of 70. I must highlight, though, that with the high levels of obesity and increasing obesity globally, we expected the trend is that we're going to see much more persons with diabetes if we continue with business as usual. So again, similar healthy diets, physical activity, maintaining a normal body weight, and avoiding tobacco use can prevent and delay the onset of type 2 diabetes. For persons with diabetes, once we detect it early, we can take them into treatment. We can avoid and delay a lot of the complications as well. So, what is the situation in Jamaica? And what is striking about this particular chart? Let's keep you guys active and interactive. What do you think is so striking when we look from 1945 to 2014, the leading causes of death? What do you... Moving from infectious to none, but right. And this has been many, many years. So this is a silent, we call it a silent epidemic. We call it a tsunami because it comes as waves, because it takes a very long time for the disease to develop. But as you can see, for some time from 1982, cardiovascular diseases have featured as the leading causes of death. And we attribute this, yes, to aging population, but that alone does not only explain it, because we're also finding younger people with some of these diseases and the risk factors. So NCDs is the leading cause of mortality for us in Jamaica. We have over about 7 out of 10, or 67% of deaths were due to non-communicable diseases. 35% of those were due to cardiovascular diseases and 11% diabetes. So you are looking at almost half. If we added cardiovascular diseases and diabetes, half of the deaths are due to these two diseases, which we know they are cost-effective interventions to address them. This just highlights again, this is the Health and Lifestyle Survey. Yes, the data is quite old, and this year we should be releasing the new data from the new survey, so that will be very interesting, because then we'll be looking at a report card in terms of where we're at. And as you can see, obesity levels are high, pre-hypertension is high, hypertension is the most prevalent NCD condition that we track based on the data that we have. And as you notice, you would have heard before, pre-diabetes is also high prevalence. Highest risk factors different for males and females. So there's a gender dimension to the risk factors. Women tend to be physical inactivity, more obese, and the men tend to smoke and drink a lot of alcohol. So those are usually the gender dimension. But that may change over time, so we'll see what our new survey says to us. We know that many of the hospital discharges, again, primarily are due to the cardiovascular diseases and diabetes, and this just shows you what that is. We forecast that this is going to increase between 2012 and 2013, but in particular for hypertensive diseases. And so if we continue with business as usual, this is the picture that we're going to face. Based on a study that we'd done in 2011 about an individual suffering from an NCD spends about 1/3 of the household per capita expenditure just on healthcare services and purchasing of pharmaceutical drugs. And the poorest, the elderly, persons with hypertension spend more on healthcare than any other population. And hypertension is quite prevalent, and it is really silent. And many persons, sometimes the first time they know that the blood pressure is elevated or high is when they actually check. And they'll tell you, that, well, I feel good. So that is also one of the challenges to really addressing the problem, because many times it's such a silent problem, and the person turns up having had a stroke. And very often, if you check the history, they would have been told at some point in time that blood pressure was elevated. So what are some of the key determinants of NCDs, and in that context, cardiovascular disease and diabetes? So there are many factors that lead to these diseases. There are the biological risk factors, which include overweight, obesity, high cholesterol, high blood sugar, high blood pressure. These are the ones we cannot change, we can change. And then there are the modifiable, non-modifiable ones, like your age, your sex, yes, genetics. And who knows, maybe on the horizon, some of these things we can modify. So, and our behavioral risk factors. So the tobacco use, the unhealthy diet, the physical inactivity, the alcohol use. And these are usually a challenge. But that is all in the context of many environmental determinants. So housing, income, physical infrastructure, access to medicines, the level, the strength of your health system. And a lot of these behaviors are also driven by urbanization, globalization. Many of the, before people used to walk many places, yes, take public transport. Now, as soon as you can afford to buy a car, get a car. And if you could park right outside this door, we would do that, yeah? Right? And if we could get something that could move us to our chair, we probably would, yes? So what's important from this is that whilst we realize there are individual factors, and from a public health standpoint, the environment shapes how we behave. So if at lunch today, if I said I only serve water, yes? Fruits, vegetables, if I decide I was only going to serve a set meal, that's the one you have access to. Even more so here, yeah, unless you carried something with you. So you'd either decide you're not going to eat, you're going to leave and go somewhere and come back, probably not so likely, but you're going to have what you have access to here. And so that goes for the wider society. So this just highlights, in the context of cardiovascular disease, how all of this is interconnected, and basically the risk factors are shared and are similar. So one of the things that we know with the modifiable, the one risk factors that we can change, is that they're shared. And what do you notice? Which one is common to all of these diseases? Even though we're looking at cardiovascular. What's very tobacco use, right? Then you have alcohol use, then you have unhealthy diet, physical inactivity, and of course obesity. And you have other risk factors, and there are many others, but these are the major ones, the bulk that we can make evidence-based changes to, and that we know impact or drive this particular epidemic. And so it's important to address these key risk factors. So they're shared risk factors. So our approach is in fact not silo approach, but an integrated approach. To speak about cardiovascular disease and diabetes, but it's an integrated approach. And it also includes addressing cancer and chronic lung disease, which is more around tobacco. So from this slide, from a public health standpoint, one of the things I want to highlight is that with cardiovascular disease and diabetes, you start out healthy, and then it's many, many, many years with respect to the risk factors and exposure. And of course, these are the modifiable risk factors. Yes, gene may play a role, but that can't explain the explosion of the disease that we're seeing now. But it takes so many years, 20 years or more, before you actually have any sign or symptom. And by the time you have a sign or symptom, you already have some of the complications related to the disease. So we really, from a public health standpoint, our efforts are always around trying to find methods, interventions, whether technology or so, to identify disease early way before its onset, and to change this picture. Yeah, to delay the onset or totally achieve cure. And so most people seek care when they have what? Symptoms. And very often, sometimes people turn up in renal failure. Yeah? And when you check it out, they have diabetes, but I had it a long time. Or they turn up with a stroke, a heart attack, and they have some of these conditions. So we want to detect them early. These diseases are silent. But what we know, there are risk factors that start from early, and so our approach is usually a life course, what we call from birth, from pregnancy right back to the elderly, right throughout your life cycle, to really tackle these conditions. So the unique features of the epidemic is that it's chronic in nature, so it's lifelong. For most, you don't have a cure, and so you have to interface with the health system for many, many, many years. It frequently, because they share a lot of the risk factors, most of our patients in our health centers, at least in the public setting, most of them have both hypertension and diabetes. Few have just diabetes alone. And the evidence shows that many of these risk factors are at risk also for, like, if you have diabetes, colorectal cancer, and other diseases. So you have to have a holistic and comprehensive approach to the individual that's in front of you. So you know, even though we're speaking about cardiovascular disease and diabetes, you need to think of all the different risk factors. So a life course approach, because the risk factors begin as early as in utero. So we know there's a lot of evidence to say for the mother, pregnant woman, both overnutrition, which is obesity, undernutrition, sets up her child in utero for the risk of diabetes and cardiovascular disease down the line. So you have to start the intervention early. And then we have to work with many, many, many different sectors, because as you can see, it has the impact on your environment, access to medicines, ensuring you have a safe space to engage in physical activity, ensuring you have access to clean potable water. I mean, there are many different components, and that requires working within government sectors, outside of government, with you as pharmacists here, but everybody has to be part of that process. So there are several targets that we have committed to with respect to cardiovascular disease and diabetes globally, and and this is for us to see a 25% reduction in premature mortality due to cardiovascular diseases and diabetes by 2025. And if we're looking at the Sustainable Development Goal, it's by a third by 2030. And the world is really not on track to meet this target. And so there's a lot that we have to do. We also have a target to ensure that 50% of those persons who are eligible to receive drug therapy and counseling, including for glycemic control, to prevent heart attacks and strokes. So we are now, in this new survey, we'll have some baseline data with respect to that. And the global target is to halt the rise of diabetes, so it's a 0% target. Anybody have ever heard of a 0% target? Right. So the world, but you know, Jamaica target is 5%. So we have gotten a very ambitious target, right, to do that over 5 years. I'll show you the plan shortly. And then 25% reduction in the prevalence of raised blood pressure, or according to our national context. So this is our guiding document. We've had a series of policies, such as the Policy for Promotion of Healthy Lifestyles in Jamaica, several, the CARICOM Port of Spain Declaration, the Nassau Declaration. So we've had many policies that we have that have framed or guided the development of our national plan. And so there are several targets related to addressing cardiovascular disease and diabetes. Specifically, they are harmonized with the targets which I just showed you a while ago. For more information, you can visit our website. So what are some of the key public health strategies in addressing cardiovascular disease and diabetes at the population level? The first thing is case prevention through reduction in modifiable risk factors. So you want to reduce these risk factors. So if you identify the risk factors early, you can intervene through screening, and you may use pharmacological or lifestyle interventions targeted individuals with pre-diabetes and pre-hypertension. So you would have heard a lot about that earlier from Prof. Toller-Reed. Improved diagnosis and control of blood glucose, hypertension is important. Improving the management of the complications and overall cardiovascular risk. So there are several interventions, and I'm settled for this particular framework will speak to two major global interventions, and these are the World Health Organization best buys, and recently in 2018 a publication that was put out called HEART. And so what happened in 2011 when we had the world came together and signed off on the UN political declaration on non-communicable diseases. This was driven by the Caribbean. As you know, when we really believe in our cause, we really provide that leadership for the agenda to move forward. And heads of nations, the UN recognized that non-communicable diseases, including cardiovascular disease and diabetes, was just not a health problem, was a global development problem, impacted on development and our societies. And so the WHO developed this essential package of non-communicable disease interventions with a focus on primary health care and low resource settings. So from a public health aspect, in order to tackle NCDs, primary care is going to be essential. And we're not just looking at primary care with respect to just public setting, but in general primary care, both public and private setting. Because persons have to interface with the facility for many, many years through repeated follow-up visits because of their disease. So this protocol is for the assessment and management of cardiovascular risk using hypertension and diabetes and tobacco as entry points to this. And the protocol looks at the routine management of both and screening. And so at minimum, countries such as Jamaica should be implementing this minimum package of care is a recommendation. And the WHO best buys are evidence-based, cost-effective, and the cost, they've worked out the cost, average cost for each setting. And recently, last year, in our setting, we have looked at the cost. It would be to, in fact, implement such a package in Jamaica. So these are, and I'm not going to go through each one of them, but it looks at from drug therapy to secondary prevention of rheumatic fever, rheumatic heart disease, early detection, treatment, control of hypertension. And these are some of the core interventions that should be in place to be addressed. For diabetes, again, lifestyle interventions, vaccination, preconception care, retinopathy, screening for diabetic retinopathy and treatment, care of acute stroke rehabilitation, foot care, educational programs. These are some of the core interventions that have been highlighted in this core package of interventions. So now, in looking at the WHO recently in 2018, just this year, they have now put out the HEARTS package which looks at healthy lifestyle, counseling, evidence-based protocols, access to essential medicines and technology, risk-based CVD, and team-based care and systems for monitoring. And so the rest of the presentation will look at the approaches to addressing CVD and this is from a public health standpoint, and they have several models to support these interventions. And really, if you address cardiovascular disease and diabetes, those risk factors, you're going to impact on several other diseases and conditions, which we have not necessarily listed there. So it focuses on primary health care. And so the first component of it, we're going to look at healthy lifestyle. So we mentioned the risk factors. The promotion of healthy diet is a critical component of addressing cardiovascular diseases and diabetes from a public health standpoint. And so the risk of CVD is increased, both CVD and diabetes, by unhealthy diets. And this is usually diets low in fruit and vegetable uptake, high in salt, high in fats, and high in sugars. Yes, like our sugar-sweetened beverages, yes. So that may be high, very high in sugar. And so diet is a critical risk factor. In fact, to address obesity, about 80% of it is around diet, and then 20% around physical activity. So the composition of diet depends on the individual needs. It also takes in the cultural context and locally available foods. So how many persons know that we have a national food-based dietary guidelines? Can I see a show of hands? No, wow. So we know we have to do a session on that, but the dietary guidelines are actually available on the Ministry of Health website. So we do have one, a guideline which is locally relevant and really takes into consideration our cultural context. So usually to get your individual needs, you need to do your nutrition counseling so that it can be specific to each individual in terms of their health and dietary needs, because you have to also take in consideration whether they have any other chronic illnesses, etc., comorbidities, in putting it together. But this is the basic element of what a healthy diet would be, based on WHO guidelines and generally utilized everywhere, is that the first thing you need to eat a variety of food. So we're not saying don't eat this and that food, but it should include a range of fruits and vegetables, whole grains, foods from animal sources. You should have at least 5 portions of vegetables and fruits per day, less than 5 grams of salt per day, which is equivalent to a level teaspoon. And I'm sure we're having much, much more than that. And if you read your labels, you should read your labels, because very interesting, many of the products that we're consuming have both salt, high in salt, and both sugar. So the next time you read your labels and look at actually how much of this is in your products. So in somewhere I went and there was a package of salt, and yes, when you read the label, there was also sugar in the packet of salt as well. There was some sugar. So the total energy intake from free sugars should be less than 10%, and that's for a person of a healthy body weight. So that is about 12 level teaspoons. And if you want additional benefits, you should drop that to about 6. And this is of free sugar, and free sugar is that added sugar and that you have. We're not looking at the sugar in the fruit that you may pick and eat as intrinsic sugar. We're looking at sugar that may be added. And so this is why we have this campaign looking at sugar-sweetened beverages. So promotion of physical activity is also important. So physical inactivity is very high in our population. And so people who are insufficiently active are about 20 to 30% more likely to die prematurely than those who are sufficiently active. Right, so WHO defines physical activity as any movement produced by skeletal muscles of the human body that uses energy. And it covers a range of movements. So your daily life, gardening, walking, playing, household chores, we're encouraging people to be more active. Physical activity that involves exercise is more what we call structured physical activity. So we are really encouraging persons to move more. You have been here for how many hours? Did we have a physical activity session here? So that'd be important to be moving. Right. So these are just the recommendations for physical activity. And these guidelines we have adopted locally. And so for adults, you want 150 minutes of moderate physical activity spread throughout the week. Or you can do 75 minutes of vigorous physical activity. That can be fast swimming, playing sports, vigorous gardening. These are some of the things you can do. Some people just turn on music and dance for an hour, or walk for an hour or half an hour right there in their room as part of their physical activity, or they come off the bus earlier and walk. So for additional benefits, you would need to increase the time you would do it, and the frequency and intensity. What is important, though, I want to emphasize as we promote physical activity, is that you need to get yourself checked. You need to do your medical assessment. Many persons are embarking on a physical activity program and have never seen a doctor, or don't even know what the blood pressure is. So it's very important so that the physical activity can be tailored to you and you know whether it's contraindicated. But these are the general recommendations for persons who are able to do these activities. So the other risk factor is tobacco. And we know a lot about tobacco. Kills about half of its users, more than 7 million persons each year. Sorry, I have a typo. 10% of these deaths are a result of secondhand smoke. And that's important to emphasize. The smoke-free laws that we have a lot about secondhand smoke. And there's what they call third-hand smoke, which is the smoke which is left in your curtains, your carpet for people who smoke, yes, in their area. So, they have detected many of these carcinogenic substances, even after cleaning out cars that people who used to smoke used to use those cars. You can still pick up some of these substances. So tobacco is very addictive. The products are, you have smoked tobacco and you have smokeless, and you have your ends, what you call it, your nicotine, electronic nicotine devices that you see a lot of persons using. It's quite fashionable now. And tobacco smoke contains about 250 harmful chemicals. We know about 69 of them cause cancers. What is important, it damages every aspect of the body, any part of the body, so it's not just the cardiovascular risk. There are many benefits from really reducing tobacco use for persons. The health benefits, after a year of quitting, the risk of heart attack and angina is actually halved. 15 years after quitting, the risk of heart attack and angina is the same as a non-smoker. And quitting after a heart attack reduces the chances of having another heart attack by half. And in fact, this is one of the risk factors I like to heavily emphasize. So you might be physically active, you might be eating well, you might not be using alcohol, but if you're smoking, you're going to still have those serious risks, and you run a risk of having a heart attack and stroke. There is a social aspect of quitting, certainly beneficial to, we're in a society where most of the people don't smoke, financial, the cost of actually purchasing these cigarettes and the cost of the hospital bill just to treat condition. Harmful use of alcohol is also another aspect, and that basically is drinking that causes detrimental health and social consequences for the drinker, the people around them, society at large, as well as patterns of drinking associated with the increased risk of adverse health outcomes. So harmful use of alcohol is not the occasional wine or something you may consume. So the risk associated with the alcohol is linked to the pattern of drinking, the amount consumed, and the quality of the alcohol consumed. There's no definition really for safe or non-harmful use, but individuals are generally considered to be at a lower risk for negative consequences of alcohol use. They drink no more than 2 units of alcohol per day and do not drink on at least 2 days of the week. So the less you drink, the less risk or harm. And in fact, from the WHO or other research and evidence that has come out, there are about 200 different health conditions that are caused by the harmful use of alcohol. So there are several interventions that can be used to address it, and there are brief interventions which are utilized in the primary care setting. And these are just some of the tools. So I just want to highlight, in terms of our approach to addressing alcohol use, tobacco use, physical inactivity, and diet, brief interventions are used as a counseling tool for the individual as a part of the public health program. And these could be from 3 to 20 minutes. For tobacco is about 5 minutes. And this is really to motivate, to assist the patient in actually doing something about their particular behavior. This is just an example. So the 5s are ask, advise, assess, assist, and arrange. And this is just an example from the HEART manual, which looks at just a simple approach to trying to facilitate persons addressing their behavior. And then there are evidence-based protocols. Jamaica has, do you know which protocols we have in Jamaica? Protocol for diabetes, guidelines for diabetes management and hypertension. And we have had evidence-based protocols from 1996 around, which we try and update periodically. So the main aim of these guidelines are to ensure that we have a standard of care, and that everyone, a minimum standard of care, because you have to treat the patient who is in front of you, and so that we can improve the quality of care. And so it's important to have these evidence-based protocols. So this is just a sample that shared from the WHO algorithm. In terms of cardiovascular disease risk, we have what we call these risk scores. And so cardiovascular disease risk, it's important that if we want to reduce the cardiovascular disease risk, we have to ensure we identify the high-risk persons, and we ensure that we have the interventions that are proportional to their risk. So this is just to show you, this is actually part included in our hypertension guidelines. This is a risk card, and which is different for persons with diabetes and whether they have hypertension. And it's also region specific, whether, so if you're in the region of Americas, we have a different card. And so it uses a stoplight phenomena to really identify where you are in terms of risk. And it looks at parameters such as your age, whether you're a smoker, your blood pressure, and sex. So if blood pressure was reduced by about 10 to 15 millimeters mercury, and about the systolic, and 5 to 8 for the diastolic, and cholesterol by about 20%, combined with your antihypertensive treatment, your statins, and other lifestyle modification, we could really reduce cardiovascular disease mortality by up to 50%. So there's a lot that we can do with some of these interventions. Targeting persons who are at risk is important, and we use these charts to do that. Another important component is ensuring access to essential medicines and technology, ensuring that we select the appropriate drugs, technology, manage the supply chain so you don't have stockouts. So if you're managing your patient, you refer them to the pharmacy, you want to ensure that they can get these drugs and ensuring how the drugs are used. So these are just a list. I won't go through them, but these are minimum list of drugs that should be available if you're going to manage cardiovascular disease and diabetes in a primary care setting. So there's a minimum. And there's a minimum set of technologies that should be available. And you may look at this should be an easy fix. Yes, all health facilities should have these in place. Rational use of medicines is very, very important. And this is something that is always a cause of concern. We just went through our VEN list and have revised that. And patients receive medications that are appropriate to their clinical needs in the doses that meet their individual needs at the appropriate time, and they're low cost to them and the community. So that's very, very important. And these are some of the things that need to be in place. Need to have clinical standards, need to have your essential list, need to ensure that persons are educated as to what is in the standards and what is the list. If you're looking at what to put on the list, ensure that you have really good advice and around that. And we also need to raise awareness, not only of healthcare workers, but we need to raise the patient's awareness. And some of the issues you find why patients don't comply to the medication is, one, they don't understand the disease. Two, they don't know why they're taking all of these things that you're giving them. And so that's important. So the other thing is a team-based care. It's important that you work as a team. And in looking at and the recommendations coming out of HEART, and we have been doing this for many, many years in a local setting, is the whole issue of task shifting. So when you have your team who can do what particular task, where you can have someone of a higher trained person doing a more higher level task, and you have persons assisting you. So you have pharmacy assistants, you have technicians, you have persons who are part of the team, you have your family nurse practitioners. So you have had a lot of task shifting over the years, and so important that you have a team-based approach. Some of the advantages when you work as a team to improve patient care and you're proactive to improve better patient outcome is that you improve coordination, improve adherence, team morale. You also reduce the time and cost of care. And some of the challenges we do have is the rapid turnover, high turnover of staff. So when we train and do some of this capacity building, we have changes in staff, sometimes attitudes around these changes, and sometimes we don't have enough policy to support some of these things. And also patients' attitudes to these changes, because they have an expectation, the patient has an expectation, I'm going to come and see a certain provider, whether it's the doctor, the nurse, or the pharmacist, and they have different expectations. So this just shows you a model which they used in Cuba just to look at how they distributed staff responsibility for the management of hypertension. As you see here, in this case, they had their pharmacists identifying barriers, lifestyle counseling, looking at BP checks, patient follow-up. So there are many different categories of workers, and this is country dependent as to how you implement it. These are just some flow charts, which I won't stay on, but just to highlight, there are different flows and different models. One is in Thailand, one is Kaiser Permanente in terms of how they looked at patient flow to improve that, to improve access to care, better quality of care, and less time for the patient. Monitoring, and finally monitoring is a critical component. Once you have your public health program and You have to monitor the program at both health facility level, national, and population level. This really tells us whether we're making a difference. And this is usually the weakest part of most public health programs. So after we have, worked through this, we have not been able to address, we don't have the data to really know how well we're doing. However, with respect to our setting, we do have systems in place both at primary health care level and in a hospital level where we do some patient monitoring, and that data is aggregated for our different facilities. We also have population-based surveys such as a health and lifestyle survey. We have some youth surveys that monitor some of these conditions. And these are just some of the data that could be collected at different health facilities. We have introduced both a chronic care passport in the primary care setting, in the public setting, and we also have a diabetes and hypertension register. Pharmacists, there are many, many different roles you can play. These are just a list from screening, monitoring, counseling, lifestyle and adherence, providing medication, promoting public health, educating patients, individuals, training, capacity building. Contributing to policy formulation is very important. Many times we don't realize that you are there seeing the patient, interfacing with the patient in that setting, and so it's important that you also make a contribution to policy formulation, and that can be through your representative. And also leading by example. So you should be leading by example, embodying some of the healthy lifestyle practices. Many programs I know people know for many of their conferences, they ensure that they vet what it is they're providing to the conference persons attending the conference. They ensure to incorporate physical activity as a part of it. So your take-home point, the public health approach, very complex, very comprehensive, team-based. There are cost-effective interventions and best buys. Many of them we are already implementing. And thank you, and that's the end of the presentation.